Moderating this session, we have Dr. Paridhi Kalar. She is a senior resident at RML Hospital, New Delhi. The case will be presented by a postgraduate student, Dr. APPEC Jain. He is a postgraduate student from RML Hospital, New Delhi. Over to you, ma'am.
Okay, good morning, everyone. Can you hear me now? Are you able to hear me?
Yes, ma'am, you're very much audible.
Okay, right. So the case is tracheostomy and Dr. APPEC Jain is going to present. So APPEC, the format will be like that you present the case as it is a short case, and I will ask questions when you have finished the case, right?
Yes, ma'am. Good morning, everyone. I'm here to present the case of one 19-year-old male patient who is a student by profession from Delhi. He was brought to the emergency department 7 days back following a road traffic accident by his relatives. At the time of admission, the patient was unresponsive and unconscious. Hence, he was intubated and put on ventilator support. He underwent evaluation as per primary and secondary survey protocol for trauma-associated injuries. Thereafter, the patient was transferred to the ICU for further management. In ICU, the patient was diagnosed with diffuse axonal injury, grade 3. He had no other associated injury. On day 7, he was tracheostomized in view of anticipated prolonged ventilation. At present, the general physical examination of the patient was within normal limits with the following vitals. Heart rate was 78 per minute. Blood pressure was 132 by 86 mm of mercury in right arm supine position. He was maintaining saturation at 100% on mechanical ventilation on SIMV mode with FiO2 of 50%. The local examination. The patient is in propped up position with cuff tracheostomy tube of size 8.0 mm internal diameter in situ on ventilator support. Bilateral chest rise was equal. There was no redness, bleeding, or purulent discharge seen around the tracheostomy stroma site. The tube is patent and present 2 finger breadths above the sternal notch. The cuff was adequately inflated with inflation pressure of 20 centimeters of water. Surrounding skin was healthy. There were no subcutaneous or laryngeal crepitus. On auscultation, the bilateral air entry was equal with there were no other abnormal findings in systemic examination. The diagnosis of the patient is the patient with head injury with grade 3 diffuse axonal injury with tracheostomy tube in situ on ventilator.
Okay, Dr. APPEC. So you've nicely presented the short case of tracheostomy.
Yes,
the first question is to you: when you have a tracheostomy patient, you always see whether the tube is patent or not.
Yes, ma'am.
The tube was patent in your case.
Yes, ma'am. The tube was patent. Ma'am, the chest rise was bilaterally rising equally. The peak pressure on the ventilators were within normal range, and the difference between peak and plateau pressure was less than 5 centimeters of water. And ma'am, on auscultation, the bilateral air entry was equally heard, and there were no added sound. There were no conductive sound heard on the auscultation.
Okay, APPEC, but whenever you say the tube is patent, you have to see whether there is any sound which is coming from the tube. You don't auscultate, you auscultate the chest later on, but first to see whether there is any sound which is coming from the tracheostomy tube per se.
Yes,
and, yes, you rightly said that you need to see the peak pressures and peak plateau pressures, whether there is an increased difference between them. But when patient is on pressure support, then you have already set the pressures. Then
yes,
you will see a rise in peak pressures when the patient is on pressure support. Then you have to take him on the VCB mode, that is the volume assist control mode, and then you see the peak pressure.
Okay.
Right? If the patient is on pressure support, then if there is an obstruction, the tidal volume will decrease.
Yes, ma'am.
And the pressure will remain the same. Okay. APPEC, what do you understand by what are the types of tracheostomy you know of?
Ma'am, tracheostomy can be surgical tracheostomy or percutaneous tracheostomy. Ma'am, it can be temporary tracheostomy or permanent tracheostomy. It can be early tracheostomy or late tracheostomy. It can be high tracheostomy, mid tracheostomy, or low tracheostomy.
No, so I want to understand what is the difference between surgical tracheostomy or percutaneous tracheostomy.
Ma'am, in surgical tracheostomy, we put the tracheostomy tube under vision by incising the anterior wall of trachea between the cartilaginous ring. And ma'am, in percutaneous tracheostomy, we use a dilator to dilate the anterior tracheal wall to form a stroma so that we can insert a tracheostomy tube.
Okay, right. So in surgical tracheostomy, you're putting the tube under direct vision by dissecting the tissues and creating a window in the trachea.
Yes,
But
ma'am.
percutaneous, you're just dilating the trachea. Good.
Yes, ma'am.
So what do you understand by early and late tracheostomy?
Ma'am, early tracheostomy is generally said to be done when it is done before 10 days of mechanical ventilation support, and late tracheostomy is usually done after 10 days of ventilation support.
So, okay, so the guidelines, they vary. So the definition can be less than 7 days or more than 7 days.
Yes,
Some between 7 to 10 days is early and late is after 10 days. So it can vary according to the work, according to the people who want to see the effect of tracheostomy.
Yes, ma'am.
That brings out us to a very pertinent question. What are the indications of tracheostomy?
Ma'am, indications for tracheostomy can be broadly divided into two main indications, that is maintenance of airway and long-term mechanical ventilation. Ma'am, in maintenance of airway, patient with a low GCS, they may require tracheostomy, and a patient with upper airway obstruction, like in case of trauma, tumor, or previous surgery or burn patient. Ma'am, in long-term mechanical ventilation, lung pathologies like ARDS, pneumonia can be indication for tracheostomy. And certain neurological condition in which patient may require long-term mechanical ventilation, like Guillain-Barré syndrome, ma'am, and ma'am, paralytic scoliosis.
Okay, so the one indication can also be management of secretions. Suppose a
Yes.
patient have large volume of secretions, and to manage high volume of secretion, patient may not be able to cough out, and you require a tracheostomy for that.
Yes, ma'am.
That is right. And what I want to know is that what are the how do you choose whether you want to go for a surgical tracheostomy in a patient or a percutaneous tracheostomy?
Ma'am, there are no absolute contraindication for percutaneous tracheostomy. It mainly depends on the expertise of the person who is performing the procedure. But in certain cases,
which is better? In the ICU, either you should go for the surgical tracheostomy or you should go for a percutaneous tracheostomy.
ma'am, in percutaneous tracheostomy, there are less chances of complications like bleeding. So it is more preferred in ICU setting. And there is no need to transfer the patient to an operating room. And ma'am, in surgical tracheostomy, we use a scalpel to incise between the tracheal rings. So they can be trauma to tracheal rings. Whereas in percutaneous tracheostomy, we use a dilator. So there is less chances of injury to the tracheal rings.
Okay, so ideally in ICU patients, you should always screen the patient for percutaneous tracheostomy. But if there are some contraindications which are relative now, there are no absolute contraindications, then you should go for the surgical tracheostomy.
Yes, ma'am.
If I say relative contraindications, then what are the relative contraindications I want to know?
Ma'am, in patient with in obese patient, ma'am, where anatomical landmarks are difficult to palpate. Ma'am, in patient with unstable cervical spine, ma'am, where hyperextension of neck is not possible.
Okay.
Ma'am, in patient requiring high ventilation support, with PEEP of more than 10 centimeters of water and FiO2 of more than 70%.
Okay.
In children's, because their trachea is more compliant, so surgical tracheostomy is preferred over percutaneous tracheostomy.
All right. And one important contraindication is?
Uncontrollable coagulopathy. In this, PCT is not generally preferred.
Yes, if there's the uncontrollable coagulopathy, which means that the APTT is more than 1.5 times the normal, or if the platelet count is less than 50,000. Then you should not ideally go for it. But now some case studies have come and they have done the tracheostomy even in these conditions by giving prior FFP or platelet transfusions. So these are the relative contraindications.
Yes, ma'am.
So how many types of percutaneous tracheostomy you know of?
It can be Ciaglia's percutaneous tracheostomy can be done through Ciaglia's technique. There are two modifications of Ciaglia's technique. One is blue rhino single dilatation technique, and other is blue dolphin balloon dilatation technique. Then, ma'am, there is Griggs guide wire dilating forceps technique. There is a Frova's rotational technique, also known as percute twist. And, ma'am, the last one is the Fantoni's translaryngeal tracheostomy.
Okay, so there are many techniques, but the most common which is used is?
Ciaglia's blue rhino single dilatation technique is most commonly used.
Okay, so have you assisted one tracheostomy?
Yes, ma'am.
So do you know the steps of Ciaglia blue rhino technique?
Yes, ma'am.
Okay, can you enumerate them?
Yes, ma'am. Ma'am, first I'll confirm the NPU status of the patient. I'll check if the written, if the consent is signed by the patient and his attendant.
The consent would be signed by the relative, yes. Yeah.
I'll check the complete blood count and coagulation profile of the patient.
Okay.
Then, ma'am, I'll position the patient by putting a support between the shoulder blades so that the neck can be hyperextended. Ma'am, I'll give 100% FiO2 to the patient. Then, ma'am, under direct vision, I'll deflate the endotracheal tube and remove it a little, pull it little outside so that the cuff of the endotracheal tube lies just behind the vocal cords. Then I'll fix the tracheostomy endotracheal tube at that point. Then, ma'am, I'll prepare the part by cleaning and draping. Then, ma'am, under fiber optic guidance, in the midline, I'll insert the 14 gauge needle cannula assembly. Then I'll check if it's in the midline through the fiber optic bronchoscope. After confirming the position, ma'am, I'll remove the cannula. I'll remove the needle leaving behind the cannula. Then I'll insert the J-tip guide wire through the cannula. After that, ma'am, I'll remove the cannula leaving behind the guide wire. Then, ma'am, I'll introduce the guide wire sheath through the guide wire. After that, ma'am, I'll use a 14 gauge pre-tracheal dilator, ma'am, to dilate the skin. After that, ma'am, I'll introduce the blue rhino dilator after dipping it in normal saline or distilled water. And, ma'am, I'll insert the dilator in a pen holding fashion till the 36 gauge mark. Ma'am, after that,
I know this, yes.
Yes, ma'am. Ma'am, after that, I'll remove the dilator and insert the tracheostomy tube along with the stylet through the guide wire and position the tracheostomy tube inside the trachea. After that, I'll remove the guide wire along with the stylet. Then, ma'am, I'll connect my tracheostomy tube to the ventilator and check for the ETCO2 reading and bilateral chest rise. After confirming the position of tracheostomy tube, ma'am, I'll fix the tracheostomy tube and remove the endotracheal tube.
Okay, that's nicely said, Arpit. But you didn't miss out few things that before tracheostomy, before positioning the patient, it's very important to check the patency of the endotracheal tube.
Yes, ma'am.
It is better to do a suctioning before you make a position first. Secondly, you always check the X-ray of the patient to see whether there are new infiltrates or any other pneumothorax already existing before you do the procedure. Thirdly,
Yes, ma'am.
the air entry before you do the procedure. And you didn't mention about the incision. So what kind of incision are you going to give? You're going to put the needle, but then you'll give the incision to put the dilator, isn't it?
Ma'am, yes, ma'am. A 1 to 1.5 centimeter transverse incision can be given if,
So
ma'am,
you can give either horizontal or a longitudinal incision. The transverse or a longitudinal incision you can give. Right. So what is the landmark for this?
ma'am, we generally give
What do you do
tracheostomy.
exactly, if you don't have a bronchoscope, you have to give the incision and put the. So what is the landmark?
Ma'am, we put it in between the second and third tracheal ring. Ma'am, in the middle.
That is all right between second or third tracheal ring or third or fourth tracheal ring. But what is the landmark on the neck?
Ma'am, we'll check the midline through the thyroid cartilage, ma'am. The angle.
So there are two things. It is either two finger breadths above the sternal notch. So you palpate the sternal notch and above you take your two fingers. So 2 finger breadths above the sternal notch. Or you can come from upwards, you can feel the thyroid cartilage, the cricoid cartilage, and you can just go 1 finger below the cricoid cartilage. So you will reach the second or third tracheal rings.
Okay, ma'am.
Okay, so you told me the steps of tracheostomy. So what are the complications that can occur during tracheostomy?
Complications of tracheostomy can be defined in broadly three headings. They can be immediate complication, early complication, or late complications.
Okay.
Most common immediate complication is bleeding. Then, ma'am, there can be displacement of airway, which can lead to apnea, hypoxia, hypercarbia. They can be trauma to the nearby structures like thyroid, isthmus, tracheal cartilage, posterior tracheal wall.
Okay.
There can be failure to perform the tracheostomy in immediate complication. Then, ma'am, in early complication, there can be bleeding, chances of infection, formation of false tract, which can lead to subcutaneous emphysema. There can be formation of pneumothorax or pneumomediastinum. They can be early tube displacement, ma'am.
Okay.
In late complication, they can be patient can complain of dysphagia. They can be tracheal stenosis, tracheomalacia. They can be formation of tracheoesophageal fistula or tracheal innominate artery fistula.
Okay. So how do you manage these complications? We've enumerated almost all the complications, except that you can have pneumothorax and subcutaneous emphysema at the time of doing the procedure itself.
Yes, okay.
So how do you manage bleeding if there is bleeding at the time of doing tracheostomy?
Ma'am, first of all, ma'am, I will stop doing my procedure. Then I'll put a gauge and apply pressures so that we can stop the bleeding. Ma'am, even if after that the bleeding is not stopped, I'll take the help of the surgery team so that they can cauterize or surgically stop the bleeding.
Okay, so most of the bleeding, they are minor bleeding and they can be stopped by local pressure. So you can apply the local pressure with the gauze or a gauze soaked in ADR. So you can apply that pressure. But if the bleeding does not stop, then you need to ask for the help from the surgical team. Okay. What would you do if you have a false track? So how do you recognize that your tracheostomy tube is in a false track?
Ma'am, there will be, ma'am, decreased air entry. When I will connect my tracheostomy tube to the ventilator, there will be increase in peak pressures, ma'am. there will be formation of subcutaneous emphysema if a false text is formed.
So there will be desaturation, hypoxia, that we will not be able to ventilate the patient, the peak pressures will rise. So what is the management of that? How do you manage for the tracheostomy tube in the false passage?
Ma'am, first of all, ma'am, I'll remove the tracheostomy tube
Yes.
and intubate the patient as the patient is hypoxic, and maintain the saturation and other vitals of the patient. Ma'am, after that, I'll inspect if the stoma formation is correct or not.
So ideally, you should remove the tracheostomy tube whenever it is there, insert the endotracheal tube again, ventilate the patient, stabilize the patient, give oxygen, and then you reassess whether you are able to visualize the anatomy, or are you able to see the anatomy, you palpate the anatomy again. Because if there's lots of subcutaneous emphysema, then you will not be able to palpate the anatomy. Okay, and if yes, then you can retry again. Okay, and what if your tracheostomy tube is in situ, but there is blood clot inside it? There's a clot inside it, and you're not able to ventilate.
Ma'am, I'll try to use a suction catheter to remove the blood clot. Ma'am, even after that, it's not possible to remove the blockage. And
Yes.
ma'am, I'll intubate the patient to maintain the airway and stabilize the patient.
So, okay, so you should try to remove the blockage by suction catheter or by fiber optic bronchoscope. That's all right. But if you are not able to ventilate, then you remove the tracheostomy tube per se, because you're not able to differentiate whether it is in a false track or it is really blocked. Okay. And
Yes,
then
ma'am.
endotracheal tube again. Okay. So how much time does it take for a track formation for a tracheostomy tube?
Ma'am, it take at least from 7 days to
Okay,
form.
so 3 to 7 days. So whenever you have some tube disconnection or tube misplacement within first 7 days of tracheostomy, then you should never try to put it again, and you should try to put the endotracheal tube. Okay. We talked about the various techniques of tracheostomy. So what are the advantages of Siaglia technique above other techniques?
Ma'am, in Siaglia's single step dilator technique, patient requiring high ventilator support, there is no loss of PEEP as there is a single dilatation technique, and we don't have to remove the dilator every time to introduce another one.
Okay, so there is only one time you are disconnecting. Okay.
Yes.
Do you know of any adjuncts which are used during tracheostomy procedure?
Ma'am, we can use a ultrasonography, and
Before that, you mentioned it also.
yes, ma'am.
You can use before ultrasonography, you can use bronchoscopy. So what are the advantages of using
Yes.
a bronchoscope during tracheostomy?
Ma'am, bronchoscope will help us in checking if the needle we inserted is in the midline. It also helps us in not damaging the tracheal wall during the insertion of needle and dilators.
The posterior tracheal wall, yes. And what are the disadvantages?
Disadvantage can be, ma'am, it's not used in patient who are who require high ventilator support, as it may cause hypoxia and hypercarbia.
Yes, so when you are inserting a bronchoscope, the patient is not getting ventilated for that time period. So he may develop hypoxia or hypercarbia. So it is contraindicated in patients in whom hypercarbia cannot be
Tolerated.
well. For example, patients of head injury or patients who have increased ICP. So in those patients, we do not want hypercarbia to be there. Like, what about ultrasound? how can you use ultrasound in tracheostomy procedure?
Ultrasound can help us in appreciating the anatomy of the trachea before we start the procedure. It can help us in identifying the midline of the trachea, the structures between the skin and the trachea, presence of any aberrant blood vessel in between in between these structures, so that we can avoid damaging that vessel.
Okay, and you can use it during the time of tracheostomy procedure as well, to see whether your needle is going inside the trachea it is in the middle of the trachea, one, and whether it is between the second and third cartilage or third and fourth cartilage. As we heard in the previous lecture, you can very well appreciate the tracheal cartilages with the help of an ultrasound, and you can see, you can put your needle in between second or third and fourth tracheal cartilage, right? And so once you have done the tracheostomy, how do you manage the patient on tracheostomy? What is the care of tracheostomy? How do you take care of a patient?
Ma'am, we should use regular suctioning whenever needed. We can use a HME filter or humidifier, so that there is no crusting around the tracheostomy tube. Ma'am, we have to keep the area around stoma aseptic, so that there is less chances of infection is there. Ma'am, we have to maintain the cuff pressure between 20 to 25 centimeters of water.
Yes, so you need to inspect the area of the tracheostomy tube daily to see for any redness, erythema developing over there, or any pus discharge. And yes, you need to see the patency of the tube. You do not need to suction it regularly, only suction when it appears to be blocked. And use humidified oxygen to air to ventilate the patient. Okay. And how do you decannulate your patient? What is the
Ma'am,
decannulation?
yes, ma'am. Ma'am, there are different methods which we can use to decannulate the patient. Ma'am, one of them is will serially decrease the size of tracheostomy tube till 4 mm internal diameter tracheostomy tube, and assess the patient if the patient is maintaining saturation and tolerating the decreased size of the tracheostomy tube. Ma'am, we can also block the tracheostomy tube for 12 hours during the day, and at night, ma'am, will unblock the tracheostomy tube again. And
so you don't block the tracheostomy tube, which is of larger size. So there are two methods, as you said. Either you can keep on decreasing the size of the tracheostomy tube, or secondly, in some cases, you can straightway decannulate. Suppose a patient who has been in the ICU for long standing, been in the ICU for long period, and now he is improving, he has gained strength, and so you can decannulate right away. But if you have a patient who has increased secretions, who has large volume secretions, or have decreased muscle strength, then you keep on decreasing the size of the tube and see whether he is able to maintain or not.
yes.
Okay. One more thing I wanted to ask, what are the ways in which you can see whether your patient is doing well on tracheostomy? So what all patient monitors you have to apply when you are assessing a patient on tracheostomy tube?
Yes, ma'am. Ma'am, we'll check the vitals of the patient. First of all, patient on tracheostomy tube, if the patient is awake, he should be comfortable, ma'am. Ma'am, we can check the ventilator settings, the peak pressure, the adequate tidal volume is being delivered to the patient. There are no rise in peak pressure or plateau pressure. Ma'am, we can auscultate the patient to see if there is any blockage. There can be bronchial sounds if there is blockage. And
Yes, so you've already mentioned many of the things. And most of the things is that you should always try and do suctioning of the tracheostomy once by yourself.
Yes, ma'am.
By not asking by others. Whenever patient is on a tracheostomy, you should try and do this yourself to see how much is the resistance and what kind of secretions are there. Right. And so one more thing, you mentioned about something about Griggs technique,
Yes,
Griggs
ma'am.
of tracheostomy.
Yes,
So
ma'am.
what are the disadvantages of that?
Ma'am, in Griggs technique, we use a forceps to dilate the intertracheal ring space so that we can insert the tracheostomy tube. Ma'am, there are chances of trauma to the posterior tracheal wall while doing this procedure, trauma to the cartilaginous ring of the trachea.
Yes, so there are more chances of injury to the soft tissue as compared to the cellular technique, right? So I think the time is up here. So Dr. Paridhi can tell, do we go with more questions or are there any other questions? So Dr. Paridhi, are you going to present now?
Yes, ma'am. We are starting with just a summary for the whole topic.
Okay.
And so how to summarize the tracheostomy topic? We can divide the topic under 5 main headings to objectify the whole topic. That is anesthesia considerations for the topic. What are the types of tracheostomy to be done and what are the names of various tracheostomy tubes, various techniques and its complication like the surgical technique or the percutaneous technique. What is the role of ultrasound and fiber optic as an adjunct to the tracheostomy? And lastly, decannulation. Briefly overviewing, already the indications have been discussed. So I would just like to enumerate the 4 basic headings for indication. Like the first one is the upper airway obstruction. On the left side of the image, we can see a normal laryngeal inlet showing a normal epiglottis, vocal cords and arytenoids. Whereas on the right side of the picture, we can see acute epiglottitis, where we can assume that the airway must have been very difficult for an orotracheal intubation. Rest of the indications like pulmonary ventilation, pulmonary toileting, and elective procedure, as was in our case for a neurosurgical trauma patient. Advantages have already been discussed, types like the depending on the timing, on the cause, on the site, and the names of various tubes, cuffed, uncuffed, fenestrated, non-fenestrated. The basic role of an anesthesiologist is very important. So the considerations in everyone's mind should be that it is a shared airway, that it has to be shared between the surgeon and the anesthesiologist. The indication of the tracheostomy and its associated injury, like if it is a case of cervical spine injury, we have to restrict the movement at the cervical spine level. There has to be a close communication between the surgeon and backup plan for the airway. Like you have to know that whether I can intubate the patient through the orotracheal route in case of any catastrophe. Always keep in mind complications like loss of airway, apnea, cardiac arrest, false tract formation, hemorrhage, pneumothorax, and its management. Provide motionless surgical field to the surgeon so that adequate muscle paralysis is given and there's no cough reflex while inserting the tracheostomy tube into the stoma. For emergency surgical tracheostomy, consider the patient full stomach, always keep the suctions ready and keep difficult airway cart ready with rescue and airway plans. And for elective tracheostomy, if there is a coagulopathy underlying, you should always try to optimize it before taking up the patient for elective tracheostomy to prevent hemorrhage. Complications again have been discussed. This is a percutaneous tracheostomy set, blue rhino set, if single dilator technique. Then already has been discussed that which are the patients which are preferred for surgical tracheostomy compared to percutaneous bedside tracheostomy. And this is the picture on the left side, that is a picture, shows the pilot needle which has been taken a prick with 40 needle in the lumen of the trachea and air is aspirated back in the syringe. In the middle picture, we can see a guide wire has been inserted into the tracheal lumen and ascended all the way to carina. And lastly, in the diagram C, we can see that the tracheostomy tube is inserted and railroaded over over the guide wire and is present inside the lumen of trachea in the tracheostomy tube. So the first tracheostomy tube should never be changed 2 hours of the surgical tracheostomy. On 7th day or 10th day, it has to be done by an experienced intensivist or an ENT surgeon. It has been seen that a regular change of tracheostomy tube has significantly decreased the granulation tissue formation, and no tracheostomy tube should be continued beyond 28 days as recommended by the European Community Directive. Briefly, I just wanted to show you and make you familiarize with the ultrasound images. On the right side, this is the thyroid cartilage, cricoid cartilage, followed by rings of trachea. And similar picture you can appreciate on the left screen where the ultrasound image is shown. Like if you are placing the probe in the diagram shown on the above side, if you're placing the probe craniocaudally, you will see trachea, cricoid, and followed by tracheal rings. If you place the probe horizontally as shown in the diagram in the lower side, you can see the trachea, rings, its depth, how much depth you have to take for the prick in the tracheostomy. At what level you will get the air aspiration. On lateral to the trachea will be the esophagus, and for the lateral to be it will be the carotid artery. Is that once you're scanning it, you can see that there is any aberrant vessel bit lateral to it. If you can see a vessel, this lastly, decannulation for patients have developed the cuff reflex, swelling reflex is present, and can maintain you should consider decannulation downsizing till the patient is able to tolerate the smallest tube, and the tube is capped overnight and is decannulated in next 24 hours. So that is all about the summary of the topic. Thank you so much.
So Dr. Nitin, can we close the session or do we have some questions?
Ma'am, we have one question. I'll just read it out. In case of emergency tracheostomy, in a case of cannot intubate, cannot ventilate situation, which technique to be preferred, and how to manage if there is a false track in percutaneous needle tracheostomy in case of a difficult intubation scenario?
So first of all, in case the first question in patients who have in emergency situations, we always go for the surgical tracheostomy. So percutaneous cannot be done, and it is always the surgical airway which needs to be obtained or secured. And secondly, if you have a tube in a false trap during percutaneous tracheostomy, the first thing is you need to take it out, take the tracheostomy tube altogether, and obviously we cannot intubate, at least ventilate the patient either by vagal mask ventilation or by laryngeal mask airway, and then you reassess the area. If you are able, because if there's a lot of subcutaneous emphysema, then you will not be able to palpate the anatomical structures. So if you are able to palpate, then you can rethink of doing a tracheostomy again, and better you do it the next time either under the guidance of bronchoscope or ultrasound. And if you're not able to palpate, then you can leave that area and do not go with the tracheostomy and think some of other measures of maintaining the airway. So can you hear me, Dr. Nitin? Am I audible?
Yes, ma'am. You are audible, ma'am.
Okay. So any more questions, Dr. Nitin?
Hello.
Hello, Nathan, any more questions?
No questions, ma'am. No more questions. Sorry, we
Okay.
lost the connection for the couple of
Yes,
seconds.
yes,
That's
I
why.
could.
No
I
more
could
questions.
sense that.
Question we have.
Okay, okay.
Okay. Thank you so much, ma'am. Thank you for this informative session.
Okay, right, thank you.
Thank you, ma'am.
So without wasting any further time, we'll quickly move on to our next session. Thank you so much, ma'am. Thank you.
Okay, right.
So we'll move on to our next session. For this, I would like to invite our next chairperson. We have Dr. Vinod Baladhi. Ma'am is professor at RML and ABVMS in Dr. RML Hospital, New Delhi.
Ma'am's area
And
of
ma'am's
special
area of
interest are
special interest
fiber
are
optic,
fiber optic, difficult area management, and critical care. We also have with us another faculty, Dr. Nisha Khachru. Ma'am is professor at ABVMS and Dr. RML Hospital, and ma'am's area of special interest are pediatric anesthesia and transplant anesthesia. So I would hand over the session to ma'am. Over to you, ma'am.
Good afternoon, everyone. Thank you, Dr. Nitin, for your kind introduction. Today's topic session is on endotracheal tubes. Now, I would like to invite Dr. Aanchal Kakkad for this session. Dr. Aanchal is working as professor in ABBIMS and Dr. RML Hospital. Her special areas of interest are airway management, obstetrics anesthesia, trauma and resuscitation. Now, I would request Dr. Aanchal to take over the session, please. Thank you.
Thank you so much, ma'am. And I think they are going to play my recording.
Hello, everyone. I'm